Hello everyone, welcome to the second module of the Simpler training module. In this module, we'll talk about the Simpler validation, as well as outline the 7 diabetes indicators and benefits of using the Simpler tool. So a quick recap of the key factors of diabetes management. Number 1, statin, as in cholesterol management, I for insulin and blood glucose management, M for medication, P as in blood pressure, L for lifestyle, E for education, and R for cardiovascular disease risk reduction strategy. So these are the results of Part 1 questionnaire in Phase 1 of my research. These are the order chosen by the majority of participants as it should appear in the handout. So for statin, the results of the Delphi showed that the statin initiation in patients with cardiovascular disease should be the top priority, followed by achieve targets for LDL as well as triglyceride, and lastly, the statin initiation in patients more than 40 years without any cardiovascular disease. So a little bit about statin update. Not so long ago, a study was done among 90,000 patients, and they found that diabetes risk was 9% higher in those taking statins. So FDA from the USA quickly relabeled and took action on the statin leaflet. And what happened was they inserted this phrase that statin can actually increase the fasting plasma as well as HbA1c or glycated hemoglobin. Fortunately, the diabetes risk is small in these cases, and statin, of course, is very effective in reducing cardiovascular disease events. So statin inhibition of insulin secretion and downregulation of a glucose transporter in adipocytes. That's how actually statin works to increase the fasting plasma as well as the HbA1c. So as you can see, for statin, it's actually smaller risk with all types of statin, and it's actually higher with rosuvastatin as well as atorvastatin. So this is according to the Australian Diabetes Guideline. So under I for insulin and blood glucose management, these are the order of appearance. The first bullet point being the most important, followed by decreasing importance. Bearing in mind, there are some conditions affecting the HbA1c result, the glycated hemoglobin. So you see, HbA1c result can be very low because the patient might be suffering from hemolytic anemia, recovery from acute blood loss, chronic blood loss, or chronic renal failure. A high HbA1c result can be caused by iron deficiency anemia, alcoholism, splenectomy, steroid, stress, surgery, or illness in the last 3 months. So every time the patient comes to see you, ask about hypoglycemia events or hypoglycemia-like symptoms. There is low-risk hypoglycemia with metformin, acarbose, GLP, and DPP-4 inhibitors, as well as SGLT2. This is a summary of the reduction of HbA1c by insulin and other oral glucose-lowering medications. Insulin is still the most effective hypoglycemia agent for type 2 diabetes. However, insulin is not the end of the road for the person with diabetes, nor does it represent therapeutic or patient failure. The indicators we should look at for insulin. SMBG is recommended for patients on insulin and on oral glucose-lowering drug that can cause hypoglycemia. Target HbA1c according to individual patient. More stringent to newly diagnosed, low risk from hypoglycemia, long life expectancy, and do not have other comorbidities such as kidney, liver, or cardiovascular disease. Less stringent for people with long-standing disease, has other comorbidities, short life expectancy, and tend to suffer from hypoglycemia. These are the indicators in order of importance we should look at under M for medication. So as a pharmacist, there are 2 things you need to consider. What are the therapeutic targets for the patient? And number 2, is the patient achieving the outcomes of therapy? So if the answer is no, then yes, there is a drug or medication related problem. So there are 13 types of drug-related problems. I actually got this excerpt from when I was back in the days when I was doing pharmacology in Masters in Clinical Pharmacy in USM. And I'll go through each one of these problem assessment in the following slides. So number one, correlation between drug therapy and a medical problem. So we need to look at some of the drugs that has been prescribed without obvious medical indications. And once this medication, there are also sometimes medications that's unidentified, so we don't know what those medications are. And also untreated medical conditions. So for example, the patient might be having blood pressure, but they're not on any blood pressure medications, for example. So I've come across quite a number of patients on aspirin, but there is no indication whatsoever that they should be taking aspirin, apart from a couple of ECG results. So it's good to ask the prescriber if there is a clear indication for aspirin. Secondly, appropriate therapy. So we need to find out if the current drug regimen is effective. If it's not effective, so obviously that's why the blood glucose is not controlled, or blood pressure is not controlled, or blood cholesterol is not controlled, then it's time to look for an alternative treatment. And we also need to look at whether the current drug regimen is safe and whether the therapy is it individualized to each patient. So for example, the patient might be suffering from allergy or cannot tolerate certain medication, so is it individually tailored to that patient? So what we mean by drug regimen is, for example, dose not adjusted for reduced kidney function, for example, drug therapy that is altered without adequate therapeutic trial, so that's mostly in reference to antibiotics, dose which are too high or too low, and then PRN use not appropriate to the condition, so for example when necessary use, route of administration or dosage form not appropriate to the current condition, and length or route of therapy or the course of therapy is not appropriate. So this slide shows an excerpt from the clinical practice guidelines of diabetes in Malaysia. So 2020, the reason one, and it actually starts with basal insulin, because basal insulin has low risk of nocturnal hypoglycemia, example glargine, and for fasting glucose above the target. So this is why we should start with basal insulin first. Oral glucose lowering drug, example metformin, are continued to prevent hypoglycemia. To reduce weight gain allows smaller insulin dose as hypoglycemia risk with larger insulin dose. If not achieving a certain target, check the SMBG readings. If postprandial hypoglycemia is identified, increase activity after meals, change meal sizes, prandial insulin dose, or change basal and premix dose. So for example, we always advise patients to do this 15 minutes post-meal exercise, which according to recent research actually works. Number 4 is therapeutic duplication, receiving multiple agents without added benefit. So for example, a patient who is on 4 or 5 antihypertensive but still not achieving therapeutic target. So it's time to look at what are the causes that could have caused the rise in blood pressure. Could it be that the patient is taking a lot of processed food which contains a high amount of salt? Could it be that the patient is not taking enough fruits and vegetables? Could it be that the patient is working under stress? So this is what we should be looking at. Number 5 is side effect or adverse drug reaction. So one thing that comes into mind is the side effect of metformin. You see, metformin when taken on empty stomach or even after food, in 5 to 30% of patients can actually cause stomach upset, diarrhea, etc. So what we do is that we suggest the prescriber to change to an alternative, which is a metformin extended release, and that actually reduces the chances of a patient suffering from the side effects of a immediate release metformin. Another example would be amlodipine. I once had a patient who developed severe swollen ankles and feet upon taking amlodipine 5 milligram, and he couldn't tolerate, and he went to a private clinic and he was prescribed furosemide instead to reduce the swollen ankles as well as the feet, and therefore he refused to take the tablet. Even though I've explained to him that it might disappear after 2 weeks and you have to raise your leg for the first 2 weeks, raise and put it on a stool for about 20 minutes, he refused to listen, and therefore we need to change to another alternative. Number 6 is drug allergy or intolerance. So this is when the patient develops severe intolerance to a particular drug. So I once had a patient who couldn't tolerate the conventional insulin. She developed rashes, and therefore it has to be changed to the analog insulin. This is an excerpt from the Clinical Practice Guidelines, Ministry of Health Malaysia 2020, and it actually tells you a brief outline of all the oral glucose lowering drug as well as insulin and the chances of you getting hypoglycemia, weight change, cardiovascular disease, bone loss, and CKD from any of these medications. Number 7 is interactions either between drug and drug, or drug and disease, food, and drug herbal. So there's one potential drug interaction that's quite disturbing, which is regarding the amitriptyline, which can also cause an increase in blood glucose level, as well as some of the antidepressants. So it's good to check the literature on this, and I actually refer to this General Practice Management of Type 2 Diabetes Mellitus, the Australian guideline. And if you scroll towards Appendix K, you can actually see all the drug interactions that actually has an impact on blood glucose levels. Number 8 is the risk and quality of life impact. So we need to measure using quality of life assessment. So for my study, I actually used the WHO QOL breath questionnaire, and I managed to find significant improvements in the quality of life of patients. Bearing in mind, this is a self-reported questionnaire. Number 9 is social and recreational drug use. For example, if patient is taking caffeine, nicotine, psychotropic, or alcohol, how that affects with the pharmacological and the pharmacokinetic action of the medication. So I came across this patient who actually smokes, and when you look at the lab results, the triglycerides actually elevated. And I looked for literature and I found that smoking does increase triglyceride level. So the doctor went ahead and prescribed ceftriaxone, but I was more focused into him stop smoking. Number 10 is financial impact when patient is unable to purchase certain medications. So for example, in my setting, sometimes patients are asked to buy certain medications, for example, empagliflozin, because the quota is restricted. But sometimes when the patient is under PKP40, so the patient cannot afford to buy medications, so of course they can actually claim and get it for free under the PKP40 scheme. Also, sometimes in terms of logistics, patients are unable to come to pharmacy because they don't know how to come, or they don't have money to come, because some of my patients complain to me that the taxi fare is really expensive and they don't have anyone to bring them to collect their medication, so that could pose a problem. Number 11 is patient knowledge of therapy. For example, we can have problems with medication adherence if patient does not understand the purpose of drug therapy. They do not understand the directions, they do not understand the potential side effects, and the current regimen is not consistent with the patient beliefs. I did come across a lot of patients who did not think that taking medications can improve their glycemic control or their diabetes. In fact, they heard a lot of news from social media that taking too much medications can actually affect their kidney, and therefore some of the patients take whenever they feel like taking. Some even take maybe today and tomorrow they don't take, so alternative days. Some take one tablet instead of two tablets as prescribed. So when I come across these patients, I tell them the benefits of taking according to the proper dosage and how the medications are designed and tested to give the efficacy in the actual stated prescribed dose. Number 12 is adherence and compliance. So patient is, for example, patient does not take due to high cost, patient do not take due to adverse effects, patient unable to take oral medication, drug product is not suitable or not available for that patient. So all these can contribute to non-adherence. Self-monitoring, that's number 13. When it comes to side effects, blood pressure, glucose monitoring, hypoglycemia, food diary, and excess diary. Of course, this is what we want the patients to keep in order for them to show it to us every time they have a doctor's visit or a pharmacy visit. But this is sometimes not possible because I've come across so many patients who do not bring their self-monitoring booklet, and they tell me things like they forgot to bring because they were in a rush, or some of them just didn't bring because it wasn't impressive enough. The results weren't what they expected. So in terms of trying to assess a patient's medication adherence, there are a lot of tools out there. Of course, there is the medication compliance questionnaire, which you can actually download from the internet. I actually got permission to use this questionnaire from the author of the journal that I actually contacted. So this is medication compliance questionnaire, and of course in Malaysia we and in government settings we are encouraged to use the MyMart medication adherence tool. So when it comes to blood pressure, which is PSIMP, so we need to look at 3 indicators. Number 1, the BP target. So the current guidelines, the American Diabetes Guidelines, actually recommend the target to be below 130/80. They have given this advice and they've revised this level, saying that this is the most beneficial for patients having diabetes. Next, ACE inhibitor and ARB are the top first line treatment for patients with or without microalbuminuria or proteinuria. Reduced sodium intake, they actually recommend only 5 grams or 1 teaspoon a day. So the current guidelines from American guidelines, the ADA actually recommends less than 130/80. So under lifestyle, we've come to SIMPL. The result of the Delphi showed that consensus from the experts, they wanted exercise to be on the top priority. So 30 minutes walking, equivalent to 5 or more days a week, and a minimum of 150 minutes per week. The BMI in Malaysia should be less than 23 kilogram per meter square, and also if they are smoking, to stop smoking. Waist circumference, 90 centimeters in men and 80 centimeters in women. If they're taking alcohol, it should be less than 2 standard drinks or 20 grams per day for men and women, which translate to 285 milliliters of mid-strength beer, 30 milliliters of spirits, and 100 milliliters of wine. Of course, there's been recent reports on the harmful effects of alcohol, even wine. There are recent reports that they can actually cause cancer. So it's always important to remind patients of the risk involved. Management of stress and diabetes-related stress. So if somebody is stressed, of course, the glucose level will increase as well as the blood pressure. And for erectile dysfunction, which is common if you have hypoglycemia or your blood glucose is not achieving the targeted level, the guideline recommends a PDE5 inhibitor as first-line therapy for male patients, example sildenafil, and also foot care. daily food care regimen. Next is E for education. So in terms of knowledge and understanding of medicine, it's very important for the patient to improve their adherence. Medication storage, where they're actually storing their medications. So I had an interesting story to tell when one of my patients actually kept his insulin in the glove department in his car. So you see, he's a lorry driver, so he actually drives to where the lorry is parked, and then he puts his insulin in the glove compartment, and then he drives his lorry. And then as soon as he comes back, he parks the lorry, goes to his parked car, and starts injecting insulin because that's the time when he's supposed to inject insulin. So I've given advice to him because he didn't seem to be achieving his targeted blood glucose control, and then I gave him advice to actually not put it in the glove department, and I'm actually waiting for him to come back to see whether if there are any improvements in his blood glucose. The other is the medication during fasting month for Muslims and other religious groups. So in this case, you need dose adjustment. The clinical practice guideline has given extensive and very detailed method to adjust oral glucose lowering drug as well as insulin. So this is just an excerpt from the clinical practice guideline. I have 2 pages of those as well as insulin. So when it comes to diet and lifestyle, these are some of the resources that you can actually look up to. My favorite was the Health Hub Singapore. I actually recommended this website to a few of my patients because it was so relevant to the Singaporean and Malaysian diaspora. So for example, the food that we eat from hawker stall and from out, because we tend to eat out a lot, what are the things that we should look up for? And the one on the right is actually the NDSS website, which is actually from Australia, and gives you a comprehensive education about diabetes, how to control it, exercise, and it's pretty comprehensive because I couldn't find a Malaysian website that gives this much of a knowledge. So that's why I recommend these 2 websites. But yes, unfortunately, it's in English. So we hope that the patient has children or grandchildren who can actually translate it to them. So the last indicator of a simpler tool is the R, which is the cardiovascular risk reduction strategy. So in this case, the Delphi consensus was aspirin therapy as secondary prevention in those with diabetes with history of cardiovascular disease. So it's only as a secondary prevention, and the use of Framingham risk calculator to calculate cardiovascular disease risk and educate patient. So just remember that aspirin is not indicated for primary prevention. So aspirin therapy, 75 milligram to 162 milligram per day as primary prevention to decrease cardiovascular disease risk if only the patients have more than 10% of cardiovascular risk in the next 10 years, according to the Framingham risk calculator. So as usual, discussions on benefit versus increased risk of bleeding should be discussed with the patient whether or not they should be initiated with aspirin. So these are the indicators for part 2 of the questionnaire, which were not mentioned in the diabetes guidelines, but from results based on randomized controlled trials and recommendations from the American Diabetes Association consensus treatment. Sleep deprivation can aggravate insulin resistance, hypertension, and hyperglycemia. So replace food with high glycemic index. Example, fried rice, fried noodles, fried mee hoon, or teh tarik with low glycemic index. Example, spaghetti, lasagna, milk, soy milk without sugar at mealtime to reduce the postprandial blood glucose. So this is an example of the plate model that Suku Separuh that Malaysian government advises. These are some of the tips to increase sleep hygiene. An attachment containing important web pages is also posted on the Google Classroom. These are the indicators which did not achieve consensus from the panel of experts. Number 1, taking at least one antihypertensive at bedtime. The reason recent Time study, which was late last year, early this year, concluded that it was the same clinical outcome whether antihypertensive should be taken in the morning or evening. However, there was no harm if it was taken at bedtime, especially if patient has high blood pressure at night. The conclusion was, if the patient has more than one antihypertensive, there's no harm to take at least one at night to give a better 24 hours coverage. So this was actually published in the Time CV events, similar with evening or morning dose of blood pressure medications. The second one was whether 1 gram per 3 grams cinnamon. There has been increasing evidence that cinnamon can actually lower blood glucose levels, but they did not have a consensus from the panel of experts to be included in the SimplyTool. But again, I don't see there's any harm in taking those. Vitamin B12 supplement in patients on long-term metformin. This again was deemed not necessary by the panel of experts to be included in the SimplyTool. Encourage daily intake of tree nuts, for example, almonds, Brazil nuts, etc. Again, I did not achieve consensus from the panel of experts to be included in the SimplyTool. But again, I don't see any harm in taking those. More information on diabetes supplement, if any of you are interested, can be obtained from this website, Medscape Pharmacist. A link with important web pages is in the Google Classroom. In choosing the simpler handout design, most participants chose the bookmark design, as in the left, as opposed to the wheel design on the right. This slide is actually an excerpt from the FDA drug safety communication, new restrictions, contraindications, and dose limitations for Zocor, simvastatin, to reduce the risk of muscle injury. When you see Viotrin, it's actually a combination of simvastatin and ezetimibe 10 mg. I actually used this slide to inform the prescribers and the patients on the LDL lowering efficacy of all the statins and statin-based therapies. This slide actually shows that the statins can actually reduce LDL as well as triglyceride, and some of them even increase HDL. This is the drug safety communication on simvastatin, and here especially it says that do not exceed 10 mg simvastatin daily with verapamil or diltiazem, and do not exceed 20 mg simvastatin daily with amlodipine. And this is all the contraindications with lovastatin. We have come to the final slide, and that's the end of Module 2. Remember, if you have any questions, please do not forget to post them on Google Classroom, and I'll get back to you as soon as I can. Thank you very much.